Lovely. So it's always great for us when we have people who did part of their training with us in the Division of Child and Adolescent Psychiatry, who then go out into the world outside us to come back. So Nic, thank you for being willing to join us. Nic was trained at UCT in his clinical psychology training, and is now in private practice for people who may or may not know. And Nic is actually a very regular attendee of our academic program. So it's lovely that you were willing. I hope I didn't twist your arm, but it was lovely that you were willing to offer to do a presentation for us today. And Nic's topic, as you can see on the screen, is holding mind in mind. So Nic, I think without any further ado, I'm going to hand over to you.
Thanks, Petrus. Hi, everybody. I chose this topic because a couple of months ago, Kaylee Lawrence was doing a talk on suicide, and I made a comment about suicide from the perspective of mentalizing theory. And shortly after that, John Joe asked me whether I'd be willing to present. And I said, sure. And I thought, well, why not talk about mentalizing? I'm not an expert on mentalizing, so I had to do quite a bit of homework for this. And there's quite a lot to it, but hopefully I can just put out some ideas about what mentalizing is about and what mentalizing therapy might look like. So let me jump in, just to say also that if I make any statements which seem like I'm making statements of fact, I'm obviously just speaking from a perspective of mentalizing theory or theorists. So what is mentalizing? Mentalizing is holding mind in mind. I can, let me just show my thing. I can hold my own mind in mind. I can think about my thoughts and my feelings and what might be motivating me. And of course, I can do the same for others. I can think about other people's minds and what might be going on for them, what they might be feeling and thinking, and what might be driving their behaviors. But just some other definitions. Mentalizing is a form of social cognition. It is the imaginative mental activity that enables us to perceive and interpret human behavior in terms of intentional mental states. Seeing ourselves from the outside and seeing others from the inside. Imaginatively perceiving and interpreting behavior as conjoined with intentional mental states. The mental process by which an individual implicitly and explicitly interprets actions of herself and others as meaningful on the basis of intentional mental states such as personal desires, needs, feelings, beliefs, and reasons. So the word mentalizing can be misleading, as it seems to imply that it's an intellectual or rational process as opposed to having emotional components. But in fact, mentalizing is usually seen as most helpful when we are mentalizing about affect or mentalizing about feeling while we're having feelings. Peter Fonagy, who's one of the big drivers of mentalization-based theory, uses the word mentalized affectivity, the capacity to simultaneously feel our feelings and reflect upon their meaning at the same time, as opposed to feeling completely overwhelmed by emotions and struggling to articulate or even conceptualize what's happening for us. We can think about thoughts. We do a lot of that in CBT. And we can also feel about feelings. We can also think about thoughts, so we can feel about thoughts. Feeling about feelings, I could feel guilty about the fact that I'm feeling angry with my child. Mentalizing explicitly is possibly what some of us might do a bit of during this talk. It's about actively and intentionally thinking and talking about mental states. I can actively engage in reflecting what's happening for me and what's happening for others. When I'm mentalizing explicitly, I can shift time frames. So I could think about something which happened recently, which didn't have a great outcome. I can try and reflect on what was happening for me and what was happening for the others. involved, and using that process, I can try and bring that to bear on similar situations that might happen in the future. I can mentalize historically. A personal example, when I was 5 years old or so, I was told that a family friend had died because she'd locked herself out of her apartment, and so had scaled the side of the apartment block, but fallen from the 3rd floor and died, which made perfect sense to me. And when I was about 13, I brought this up and I mentioned it to my mother, who said no, she committed suicide, jumped from the 3rd floor window, which instantly made perfect sense to me as a 13-year-old. I had not revisited that memory, and so it was just sitting there like this concrete block in my mind of this person scaling the side of the wall. But I could see how at the age of 5 that made sense to me, because I was in a different developmental state or phase of development. I can mentalize about things that happened recently or that are happening outside of my immediate current state. At the moment, I'm having a terrible time with my intimate partner, and we're arguing, etc., etc. And I'm telling my therapist all about this. It's happening currently, but not in the now. Or we can mentalize in real time about what's happening right now, what's going on for me. And that can also happen in the therapy space, where things, emotions, feelings are happening between the therapist and the client. And I can mentalize about myself or about others, as I've mentioned. I can think about my own mental state and motivations, and I can think about what's happening for others. Of course, I have more access to my own process than I do to what's going on with others. Their minds are opaque to me. I cannot know what's going on. I can merely hypothesize. So another personal definition I have for mentalizing has something to do with being a psychological empiricist. I don't necessarily have perfect access to my own emotional states, though, because I could have feelings that I don't really understand. They could be based on things that happened when I was 2 years old, and I have no idea why I'm feeling the way I'm feeling. Mentalizing implicitly is more elusive than mentalizing explicitly. It's harder to get at. It lies beyond words. It's more intuitive. It's about procedural knowledge, automatic, non-conscious. So this is more instinctive behavior or thoughts, feelings, experiences, which raises the question, has this got to do with the psychodynamic unconscious? I always used to imagine that Freud's unconscious was a sort of dreamlike netherworld, which is full of characters and activity. But I wonder whether this idea of implicit, well, certainly the idea of implicit mentalizing makes more sense to me personally as the unconscious. And I might revisit that again a bit later. Mentalizing implicitly in relation to others. So for example, in conversation, we're chatting and we're constantly monitoring ourselves and the other, but not actively. We respond to the other person appropriately. We adjust our affect according to theirs. We're not going to continue laughing jovially as the conversation turns to something heavier and the other person becomes more solemn. But it would be weird and stilted if we were actively doing this while having a conversation with somebody. So there's perceiving and responding to emotional states. Of course, sometimes we do mentalize explicitly in conversation. So if I'm socially anxious and self-conscious and see myself through the eyes of the other, it might make it really difficult to just let conversation flow. Mentalizing implicitly in relation to oneself. This would entail a felt sense of self, a felt sense of who you are, what it feels like to be me in the process of thinking, feeling, and acting. Problems in mentalizing. So it's assumed that problems in mentalizing would be involved in all conditions that lead to referral for psychotherapy, either an inhibition of mentalizing or a failure to develop it, which isn't to say that failures in mentalizing necessarily cause the problems which bring one into therapy, although sometimes it could. But sometimes the issues that bring us into therapy themselves are inhibiting or impacting on our mentalizing capacity. Correspondingly, psychotherapy can be understood as an effort to restore or to stimulate mentalizing in our clients or patients. So Fonagy and his crew would suggest that mentalizing necessarily is found across many different modalities that use the capacity to mentalize, whether it is explicit in the theory or not. And as such, that good outcomes in psychotherapy would involve improvements in mentalizing. Mentalizing is seen as a skill, so there are individual variations. Some people intrinsically mentalize better than others do. But also the capacity to mentalize has both trait and state aspects. So I might mentalize quite well when I'm feeling cool, calm, and collected. But if I'm under duress or feeling emotionally overwhelmed, my capacity to mentalize will be compromised. And it can also be compromised in an interpersonal context. So I might be absolutely fine one-on-one, but in large groups, for example, I feel a bit discombobulated and struggle to think clearly and think on my feet. Impaired mentalizing includes not only failures to mentalize, which might, in an extreme version, be complete oblivious to mental states, other people's mental states or my own. There can also be distortions in mentalizing, so mind misreading. I am holding mind in mind, but I'm getting it wrong. So it's not necessarily a constitutional given, it's a developmental achievement. We're not born with mentalizing on board. It's something that we acquire and develop over time, developmentally. It's believed to be related to the quality of early attachment relations and adequate mirroring of subjective experience. So what is mirroring? Mirroring is the feedback that our caregivers give us about us. So feedback that they're giving us about what our subjective state or mental state might be. And it seems to facilitate the development of affect regulation, self-control, and the capacity to mentalize. It's believed that disruptions in early attachment or later on trauma can disrupt the capacity for mentalizing. For example, with PTSD, that's later on trauma, flashbacks, although they're memories about things that have happened before, can feel very real and immediate, and correspondingly, there can be overwhelming emotions connected to those flashbacks. For Fonagy, there's a correlation between attachment, affect regulation, and the solid ground for the development of reflective functioning or mentalizing. So given that attachment theory is so connected to this whole mentalizing story, I thought I might just touch on that briefly. Around about in the 50s, Bowlby brought us attachment theory, and he highlighted the attachment drive, which for him might be more important than Freud's psychosexual drives. And the main takeaway from Bowlby for me would be that he said that with a secure attachment bond, there's a secure base from which the infant can venture out into the world safely to explore. In the 70s, Mary Ainsworth brought us the famous strange situation experiment. Mother and infant in a play situation. At some point, mother leaves, a stranger comes in and engages with the child. And then stranger leaves and mom returns, and the whole time they watch what the infant does. Infant is between the ages of 9 months and 12 months of age. And already at that point, she identified 3 distinct attachment styles. When I say distinct, it's more complicated than that. There are subtypes, but there seem to be these 3 very prevalent attachment styles that are in place at the age of 12 months. The secure attachment, child plays happily, mom leaves, there's some distress, the stranger comes in and is able to calm the child or soothe them to a degree. Mom returns, reconciliation, big hug, and back to play. With the anxious ambivalent attachment, it's one of the insecure attachments. Child becomes quite dysregulated when mom leaves. Stranger struggles to soothe them, cannot calm them down. Mom returns, there's an ambivalent response. Clingy, holding onto her, but angry. Bad mommy, maybe smacking her, push-pull. Lots of emotion. The other insecure attachment, the anxious avoidant, child seems very well contained. Mom leaves, not particularly concerned. Stranger comes in, hey, how you doing? Stranger leaves, mom returns, hey, how are you doing, mom? So very contained, seemingly. Interestingly, when we plug this child into an EEG monitor, we see the same amount of anxiety in the brain that we saw with the anxious ambivalent child. So the activity is happening in the limbic system, but they're not showing it. So that could be I'm feeling it, but I'm poker face, or it could be that I'm not actually paying attention to information coming from those parts of the brain. Just another note on the on these three styles. It seems that the anxious ambivalent individual is paying more attention to the emotional information that's coming in. That's their primary way of navigating. The anxious avoidant individual is focusing more on cognitive activities. So their rational faculties, which are becoming more and more robust over time, is the primary way of navigating, where the secure attachment seems to use both, which is reminiscent of Marsha Linehan's wise mind in DBT. You have emotional mind, you have rational mind, and where the Venn diagram meets, you have wise mind, using both emotional and rational information. The attachment style at 12 months seems to be contingent on the attachment environment, and also to say that it's very stable over time. So the correlations at the age of 5 years on the 90s, a correlation at 18 years in the 80s, and at 27 years of age in the 70s. Other research indicates that the attachment style of adults generally is very correlated with their attachment style at 12 months, and it's between 68 and 75%. So that's really high. Why does it come down over time? Well, learning and also other attachment relationships, which modify the attachment templates, which is good news for therapy. It means that they can be modified. In the 80s, Mary Main discovered or identified the disorganized attachment style, which is more rare. This happens when, so the instinct is to move towards the caregiver when you're feeling fearful or distressed. But if the caregiver is the source of fear and distress, you're stuck in a double bind. It can't be resolved. And this results in this fearful avoidant, rather prone to dysregulation type attachment style, which would be correlated with borderline personality structures or complex PTSD. So attachment and mentalizing, a family of the attachment or the attachment environment of the child offers a natural context for learning about minds. Bowlby said that the secure attachment correlated with the child's capacity to conceive of the mother as having her own goals and interests separate from his own. Britain in 1979, children who were securely attached at 12 months used more proto-declarative pointing at 11 months of age. That's pointing at something for somebody else's benefit, which suggests that A, they have a theory of mind, that other person has a mind which is not mine. I can also influence that mind. Subsequently, several studies have noted that the earlier emergence of theory of mind seems to be correlated with secure attachment. Without theory of mind, others have a mind which is not mine, and I have a mind which is not theirs, is essential for mentalizing. Mentalizing cannot happen without that. There's no direct link between attachments and mentalizing. One doesn't cause the other, but it's believed that similar causal factors might underlie both. So secure attachment and mentalization may both be facilitated by aspects of parenting. And the strongest evidence for this seems to be that mothers who take a psychological perspective on themselves and their children associated with both secure attachment and mentalizing. It's seen in an evolutionary light. So attachment theory was always seen in the evolutionary light. That attachment doesn't happen because it feels good, but because infants and human infants particularly are extremely vulnerable. And if the caregivers are not attuned and focused on where they are and what's happening, a hungry hyena might make off with your kid. So it's about physical survival. But Fonagy and co. suggest that it's more than just that, that survival is also about learning to fit in effectively with social groups, and that mentalizing develops through this attachment process because it helps us to be people amongst people. They highlight the importance of recognition by the caregiver that the child has a mind of their own and a developing sense of agency. Attuned responses that convey empathy, so empathizing with what's happening for the child, but also coping. If I, as the caregiver, am overwhelmed by what's happening for the child that doesn't feel helpful to the child, a scared caregiver is not going to make me feel safe. And as I said, acknowledgement of the child's intentionality. And constantly highlighted is the synergy between affect regulation, secure attachment, and mentalizing. Contingent marked mirroring. So marked mirroring, what is marked mirroring? Marked mirroring is when the feedback to the child is sort of hammed up or processed, given back in a slightly altered form. So motherese, I think, is the best example of that, when the mother's going, he's a grumpy boy, he's a grumpy boy. That kind of sing-soggy way of engaging is believed to highlight the fact that she's giving the child feedback about its experience. It's somewhat metabolized. It's not giving it straight back unprocessed. It's believed that that would be quite overwhelming, but also helps the child to develop theory of mind, that this is somebody else giving me feedback about my mental state. We're not sharing the same experience. And feedback, of course, should be contingent on the child's experience of what's actually going on with the child. We can't get this right all the time because we don't know. But it seems that secure attachment, what we see is that about 70% of the time, the caregiver is more or less in the right ballpark and helps to soothe and regulate the child's experience. Failures of mentalizing. There can be a tendency to misread minds, both of self and others. I think a great example for me of an extreme version of failing to read one's own mind is when famously Freud went to see Mesmer's hypnosis show. And Mesmer said to the subject, when I click my fingers, you will jump up and go and close the window. And he clicked his fingers and the subject came out of the trance and went and closed the window. And Mesmer said to him, why did you close the window? And he said, it was drafty in here. Maybe it was drafty in there, but Freud was right. This person was failing to understand why they did what they did. And we can obviously misread the minds of others. And subsequently, there can be poor performance in social contexts. If I feel offended by somebody else and start yelling, and they didn't actually do anything wrong, we've got a problem. And the other thing what happens with mentalizing, failures in mentalizing can involve regressing, if you like, to pre-mentalistic modes of organizing subjectivity. And I'll speak more about this in just a second. And of course, those can disorganize interpersonal relationships and coherence of self-experience. So there's also a lot of focus on mentalizing and one's sense of self as consistent and coherent and stable over time. And when people are overwhelmed with emotion, for example, that can often lead to their sense of self being disrupted, which I think is possibly what we refer to when we talk about fragmenting or becoming or decompensating. So the modes, pre-mentalistic modes, psychic equivalence. The internal world and external reality are simply equated. What is thought is experienced as real and true, which is perfectly normal for an infant or a child up to around the age of 20 months. Things can feel too real. subjective experience of mind can be terrifying. I mentioned flashbacks, for example. It can be difficult for the individual to entertain possible alternative perspectives. If what I think is real and what you think is different to what I think, you must clearly be wrong. So there's a suspension of doubt and an overriding sense of certainty. No differentiating between beliefs and facts. So, for example, people might feel that they are treated badly because they are bad, or conversely, I am bad, therefore the world will treat me badly. My experience happens to me. I'm not a person having an experience, it is happening to me. Negative thoughts about self may feel very real. And there's mainly an internal focus. What's going on inside of me is the primary source of what's happening outside of me. Unmarked mirroring is believed to be overwhelming, as I mentioned, and could lead to difficulties with psychic equivalent. So if I imagine that what goes on in my mind is equivalent to the outside world, and the outside world is behaving as if that's the way it is, it's going to be difficult for me to decouple my internal experience from the outside world. The internal, as Bjorn said, seems to match the external. Teleological modes is when states of mind are recognized only if their outcomes are physically observable. We can recognize states of mind and their importance, but only in concrete situations. Changes in the physical world are needed to demonstrate the intentions of others. So, for example, I might be feeling really put out by something and I demand an apology and the person says, okay, I apologize. And suddenly I feel better, as if everything has changed in their perspective. So it can drive behaviors to generate observable outcomes. I demand an apology. It can also lead to people needing demonstrations of things like love and affection. I only feel love if you're holding my hand, hugging me, kissing me, telling me you love me, and do not leave the room. And there's mainly an external focus. Pretend mode. So this is an area where there are some blurry edges for me, so I'm still trying to get a felt sense of how this works entirely. But it's where the mental world is disconnected from outer reality. And we can imagine this quite easily with children in play. If I'm 4 and I pick up a stick, that stick becomes a gun. And it is a gun to me. Yes, I'm aware that it's a stick, but I can really feel the gunness of the stick. And the stickness of the stick I can ignore. So what we imagine is real and what we ignore is rendered immaterial. The self as the interpreter of experience is constrained because reality threatens what has been imagined and it can open the door to what has been ignored. It is an important developmental stage. Vygotsky said, in play, the child is always above his average age, above his daily behavior. In play, it is as though we were a head taller. He was a head taller than himself. This is reminiscent of Vygotsky's zone of proximal development. So I think is a useful idea in the therapy space as well. If you want someone to learn, you need to push them outside of their comfort zone, but not too far outside of their comfort zone. You can move from addition and the subtraction to multiplication and division, but let's not jump straight into quantum, into calculus or matrices. Absorbed in play, imagination and reality can seem entirely separate, while pretending a child can exercise and strengthen important mentalizing skills. So for example, if I'm playing with 2 dolls, my 2 dolls might be better at mentalizing than I am. Are you cross with me? No, I'm not. Why do you think I'm cross with you? Whereas in my own personal, interpersonal relationships, I'm not actually exercising that level of skill. When watched by a parent, an older child, or a therapist, the pretend world and the real world can start to overlap. So a person can say, is that a stick or a gun? I'm acknowledging the gunness of the stick, but I'm also amplifying or highlighting the stickness of the stick. And so the groundwork is laid for mentalizing. Psychic equivalence leads to pretend mode, leads to a merger of the two. Non-contingent mirroring can lead to a severance. It's believed to lead to a severance of the internal and external reality, and the maintenance of the pretend mode. It can lead to an emptiness inside. This is David Wallen, as the child is forced to internalize the parent's emotional self as opposed to their own. And here we're getting into the territory of the sort of deeper end of mentalization theory, which is psychodynamic in its origins. And we get into territories where they talk about things like the alien self, projective identification, etc., which I'm not going to get into here. In the pretend mode, discourse, so this will be later childhood, adolescence, and adulthood. Discourse may seem empty, meaningless, inconsequential, and circular. It can be marked by simultaneously held contrary beliefs. Frequently, affects do not match the content of thought. Hypermentalizing or pseudo-mentalizing. So what is pseudo-mentalizing? It's when a person can talk in great depth in a very psychologized way about what's happening for the other person. They can talk about their history and how it connects to what's going on for them right now. And it can be a very robust theory, but completely disconnected from reality. It has nothing to do with that person's actual experience. And it doesn't occur to them to check or ask. There's that sense of certainty. Also believed to be involved in dissociation, denial, and extreme narcissistic grandiosity. The narcissistic person imagines themselves to be better than, smarter than, more talented than, and they really, really see that quite clearly, and they ignore any information coming from the outside world which challenges this. If evidence is strong enough, it can penetrate that narcissistic defense, but that can lead to fragmentation and or that narcissistic rage response as they attack and try to damage the source of this challenging outside reality. Embeddedness, I find to be quite a useful concept. I got it from David Wallen, and that's when you're really stuck inside your experience. I mean, everything is feeling very real. Your thoughts feel very real, and your emotions. As opposed to mindfulness, was the ability to step back and observe your experience. I'm having these thoughts. I'm having these feelings. Experience is known to be real, and therefore I feel compelled to act. I have no choice because this is going on. When I'm pretending, experience is known to be unreal, so there's no need for action. But when mentalizing, I can reflect on how real or unreal our experience actually is. I can wonder how our internal state currently relates to the external reality, and I can choose how to act. Carnegie said that if the pathway out of psychic equivalence and pretend mode begins with containment and affect regulation, it leads to the terrain of reflection in part through the medium of play. Therapeutically, we can think of the therapy space as a secure base and a place where we can, in a sense, be in pretend mode. There's the freedom and safety to imagine, to reimagine or rethink situations in our real life as if we were out there in the real world, so we can practice, rehearse being out there in the safety of the therapy space. So what does good mentalizing look like? Some examples: we acknowledge the opaqueness of other minds and we are tentative about mental states. We have a genuine interest in mental states of self and others and how they are related. There's adaptive flexibility in switching from automatic to controlled mentalizing. Something just happened here, we were getting on fine, now the tone has changed, let's think about it. How are you doing? How am I doing? Let's talk. We're now mentalizing explicitly. Acknowledgement of the changeability of mental states. Integration of the cognitive and the affective in both ourselves and others. The ability to regulate distress in relation to others, and willingness to take responsibility for our actions. Bad mentalizing, the dominance of non-reflective, naive, distorted, and automatic assumptions, unjustified certainty about states of mind of self and others, a rigid adherence to one's own perspective, or excessive flexibility in changing perspectives. Politically left-wing, because a very intelligent and charismatic person gave me a great reason why I should be. But the following day, an equally charismatic and intelligent right-winger convinced me otherwise, and so now I've joined the Republican Party. Inability to consider both one's own and others' perspectives. Engagement in excessive and over-detailed mentalizing. So that pseudo-mentalizing, as I mentioned, would be an example. Focus on external factors, government, school, colleagues. So I'm blaming the world for wherever I might be at in life. A focus on empty, purely behavioral personality descriptors, including diagnosis. So do I see my client as their diagnosis, or is a diagnosis simply a useful way of summarizing a certain number of problematic traits or states? For example, no two borderline personality disorder people are the same outside of their diagnosis. They are unique in every way. Emphasis on either cognitive or affective aspects. Defensive attempts to avoid mentalizing, becoming aggressive, manipulative, being in denial, changing the subject. Just a quick point on misuse and overuse. Psychopaths can be very attuned to other people's mental states while lacking in empathy. And this, once upon a time, quite probably was adaptive. So if you are born in a very dangerous and violent situation, it makes a lot of sense to pay very close attention to the people around you and to have a sense of what's going on inside of them, because things could turn scary very quickly. But later in life, believing that you and only you will take care of you, you can use this skill to be effective at manipulating others into attending to your needs. But also preoccupation with your own mental state can be very distressing. So anxious and inflexible rumination, or depressed and negative inflexible rumination. Therapy. Across modalities, therapies are believed to enhance mentalizing. There's a safe interpersonal space. Therapies help to regulate affect, and therapists can offer alternative perspectives on mental experience. Mentalization-based treatment, key task is to promote curiosity about mental states and motivations, and to explain the actions of self and others. So there will be a psych ed component to it, talking about mentalizing and explaining what it is and how it works. Enhancing skill in mentalizing focuses on process rather than specific content. It's not so much about what was said, but how did you feel in that moment? What was happening for you? What was happening in your mind? What do you think might have been happening in the mind of the other person? How might they have been perceiving things? How were they feeling? Not intended to create specific insights, but rather to enhance the capacity to generate insight moment by moment in real time. Affect focus, which many therapies have in common. Focused on the patient's mind rather than their behavior. Relating to current events or activities. So there's value in mentalizing about things that have happened in the distant past. There's also value in mentalizing about things that are happening currently, but not immediately. But it's believed that the greatest value is if you can work with mentalizing in real time while the person is dysregulated or feeling overwhelmed. Can you try to help them to engage mentalizing in that space? It can't be done if you are overwhelmed or too aroused. And you can do it naturally when you're feeling cool, calm, and collected. But can you do it in that zone of proximal development? Can you do it when you are halfway between baseline and dysregulated? And that's the trick, is to try and see whether you can hold people in that space where they're not completely at baseline, but they're also not too dysregulated to engage mentalizing. Don't try to get someone to mentalize if they are too overwhelmed. It's not going to happen. Be with them, be present, allow them to settle, and then see whether you can engage the mentalizing. You can make use of the therapist's mind of a model, what I might do in a situation, an alternative perspective. And it can also be modeled by the therapist. I wonder what she was thinking when she said that to you, or I'm curious about whether something else might have been going on as well. So that's modeling the fact that you don't know and can't know, but you are curious about the mental states of others, including your client. Mentalizing the transference. So I was speaking earlier about the possibility that the unconscious might have to do with this implicit mentalizing. If we think back to the attachment templates, adults with an avoidance style tend to withdraw when there's conflict in relationships. Adults with the preoccupied or anxious ambivalent style tend to engage. So there could be lots of prodding and criticism and emotion. We're not doing this consciously. It is automatic. It's instinctive. And so in that way, unconscious. And certainly like in the neuropsychoanalytic theory, they would talk a lot about strategies that are developed somewhere between the ages of about 1 to 3 and 4 for coping with getting needs met in a suboptimal environment. But these strategies are put in place consciously, and we can't recall putting them in place in the first place. So it's part of non-declarative memory, but they are automatic and we're doing them all the time. It's assumed that these patterns will be played out in the therapy as well. That's the transference. And if the patterns can be identified, they can be brought to consciousness, so the implicit can become explicit. An example in my practice, a client of mine who would constantly apologize if she cried, or she would ask, "Is it okay? Do you mind if we talk about this thing?" Of course we can talk about this thing. This is your space. You're actually paying me. Or comments like at the end of a session, "Wow, you must really need a drink now. I mean, I've really dropped a hell of a lot on you." And in actual fact, she wasn't that intense or heavy at all. And noticing this kind of pattern, we were able to highlight it and see how there was this core idea in her that she would be too much, that she couldn't rely on other people because it would just be too much for them to bear. And we could see how that played out all over the show at her work and her personal relationships, how it played out with her parents going back as far as she could remember. Very good at helping others and would go to great lengths to do so, but felt very uncomfortable asking others for help or sharing her distress with other people. So that's hopefully if we're onto something there, making something which was implicit, explicit, unconscious to conscious. So that's mentalizing the transference. Note that therapy can trigger hyperarousal and activation of the attachment system, which can then inhibit mentalizing, particularly in disorganized patients. So you want to hold that balance, as I was saying earlier, between over-arousal and a lack thereof. Too much empathy could overstimulate the patient. Be aware of changes in affect and be ready to step back from the heat. Avoid situations where patients are expected to talk about mental states that they cannot link to subjectively felt reality. In the example I just gave, we could clearly see that if it was true that there was this unconscious program, if you like, running in her, that she can't burden others with her feelings, because we could look at that and we could look at very concrete examples and link that easily and consciously to her history, as opposed to some vague interpretation which is inaccessible. So therefore, de-emphasizing deep unconscious interpretations in favor of conscious or near conscious content. avoiding descriptions of complex mental states that are incomprehensible to the person, especially when vulnerable. Persons struggling, if they're feeling overwhelmed, they're struggling to think clearly, don't give them a very complex concept to try and take on board. They're not going to be able to get there. Keep it simple. Do not tell patients what they're feeling, thinking, what's motivating them unconsciously or consciously. You're undermining mentalizing, particularly in vulnerable patients. This is similar to the non-contingent. There's a risk of it being very similar to the non-contingent mirroring that we were talking about with the parent-child or parent-infant relational dynamic. The therapeutic stance, maintaining humility, which is derived from the fact that you genuinely do not know. Taking time to identify differences and perspectives whenever possible. Validating different perspectives, even when challenging those perspectives. Actively questioning the patient about his or her experience, asking for detailed descriptions. Often people make a comment which is quite vague and doesn't give a lot of information and move on. You can pause there and say, can you help me to understand that in more detail? What questions rather than why? And two things come to mind there. A why question can be perceived as invalidating. Why did you feel that? Might imply you shouldn't have felt that. That's a bit odd. Also, sometimes we don't know why we felt something. Our brains just generate emotions, and we're not necessarily sure why. But what are you feeling is always a valid question and can usually be explored and answered. So an effective intervention, according to mentalization-based therapy, might look as follows. So identify the break in mentalizing. And then rewind to a moment before the break occurred. Explore the emotional context, what was going on. The therapist explicitly identifies their own contribution to the break. I can see how what I said led you to feeling misunderstood or unheard or criticized. I apologize for that. Develop an understanding of mental states implicit in the current state between the patient and the therapist. A recent example for me, I don't know if it's a great example, but in fact, Monday this week, chatting to a client, and they were talking to me about being angry with their boss. And the boss is vaccine hesitant, and had recently been in contact with someone who tested positive, but nevertheless continued with a meeting in person and only told them after the fact, and he was really angry about that. And then he said, I'm not sure whether or not you're vaccine hesitant. It doesn't matter, it's irrelevant. And then he kind of got a little bit discombobulated, but got himself back on track and continued with what he was telling me. So when he'd finished saying what he was saying, I said, that moment when you told me you were wondering about my position on the vaccine, you said it didn't matter, it was irrelevant. I'm wondering what was going on for you there. And he said that while he was talking, he suddenly recognized that I might be vaccine hesitant and or anti-vax or conspiracy theorist. And he suddenly started feeling very, very anxious. And as his anxiety spiked, he was struggling to think. He was struggling to figure how he could undo what he had done. And he sort of figured maybe it was best to just move on and keep talking. We talked about that further, and he said that he wasn't concerned about whether I would judge him for his view. He was more concerned about him judging me for my view, because he said that the therapy space felt safe, and he was worried that his own judgment of me, should I be hesitant, vaccine hesitant, would damage our relationship. And so he didn't want to know. I said, well, it's a bit like the kid who doesn't want to look in the cupboard in case there's a monster in there. And he said, yeah, exactly, that's how it was. And then we were able to talk about similar processes play out elsewhere in his interpersonal relationships. So that was quite useful. I would have been slapped on the wrist if I was being supervised by Fonagy or Bateman. They would have said, why didn't you hit pause in the moment? You could have caught the mentalizing breakdown in real time and worked with it. And I would have had to say, well, I dropped the ball. And that, I think, brings me to the end of my show.
Great, thank you very much, Nic. And I think we can stop the recording now.